First part of the talk will be on neonatal sepsis, a very important topic for pediatricians. So neonatal sepsis is could be defined as systemic signs of infection and isolation of bacteria from the blood. Typically, it's broken into two major categories: early onset neonatal sepsis, which happens in the first week of life, and late onset neonatal sepsis, which happens in the second week of life between day of life 7 and day of life 28. So early onset disease is primarily due to vertical transmission from the mother, and that happens either late in utero, around the time near delivery, or actually perinatally at the time of the birth itself. Late onset sepsis may be acquired during the birth process from the mother, or may be acquired subsequently in the environment. In terms of the epidemiology, the incidence and etiology of neonatal sepsis vary quite a bit by setting and location, and also patient-specific risk factors. So the incidence of early onset sepsis in the U.S. is about 1 per 1,000 live births. It's quite a significant illness, so it carries a high morbidity. About 80% of neonates with sepsis are hospitalized in the ICU, and 15% will die. Thankfully, there's been a recent decrease over the last decade or more due to screening and intrapartum antibiotics for group B streptococcus, which is a major cause of neonatal sepsis. And this figure which was published in the CDC's recommendations on prevention of group B strep, shows the incidence of early onset and late onset group B streptococcal disease over time. And what you can see on this slide is that in the 90s, the incidence was almost double of early onset sepsis, was more than triple actually what it is today, with an incidence of greater than 1.5 per 1,000 live births. The beginning of policies for screening and prevention in the mid-90s really resulted in a rapid decrease in the incidence of early onset group B streptococcal sepsis. But as you can see from this dashed line here, the incidence of late onset group B streptococcal neonatal sepsis has really been quite flat. So these efforts at prevention are primarily geared toward preventing transmission of group B streptococcus at that perinatal stage, but they don't really address the late onset disease. So risk factors for neonatal sepsis for all causes, not just group B streptococcus, are prematurity. So preterm infants are at higher risk. And then, as you would think, the risk factors that result in the possibility of ascending infection into the uterus are associated with higher risk. So prolonged rupture of membranes, maternal temperature, signs of chorioamnionitis are correlated with a greatly increased risk of neonatal sepsis, and then fetal distress at the time of delivery are also associated with risk of neonatal sepsis. For group B streptococcus specifically, maternal group B streptococcus colonization, which is typically measured in a urine test, is a risk factor for GBS disease, and specifically for early onset group B strep infection. The other risk factor for group B streptococcus neonatal sepsis is a history of previous delivery of an infant with group B streptococcus disease. So in terms of the etiologic agents of neonatal sepsis, I've already touched on the most common, that's group B streptococcus. Now, this is the most common in the U.S. This is not necessarily globally the most common pathogen. In fact, in a lot of resource-limited settings, for unclear reasons, group B streptococcus is not the most common cause of neonatal sepsis. Escherichia coli, which is a gram-negative bacteria that colonizes the intestine and can cause urinary tract infections and other infections, is the second most common cause of neonatal sepsis. And a lot of the pathogens that you classically learn about as causing neonatal sepsis, others include Listeria monocytogenes, although to be honest with you, that's quite rare. And I'm going to actually show you real data on the incidence of these various pathogens in a couple of slides. Other organisms include Staph aureus, Enterococcus species, other gram-positive cocci, and then other gram-negative enteric pathogens as well, in addition to E. coli. The gram-negative infections, I want to talk about some of the individual ones just because there are a few notable features. So the E. coli that causes neonatal sepsis notably has a very similar capsular structure to Neisseria meningitidis, and this may be one of the reasons why it's able to cross the blood-brain barrier, cause meningitis. It's also notable just because it can cross-react with some of the serologic, the antigen diagnostic tests for Neisseria meningitidis. Klebsiella pneumoniae is among the most common causes of neonatal sepsis in many sites outside the United States. So in many resource-limited settings, this is an important cause of neonatal sepsis, but not very common in the U.S. Enterobacter species are notable for, as well as Citrobacter species and Serratia are all notable for a few reasons. One is they're very often resistant to antibiotics, and they may be resistant to extended spectrum beta-lactam drugs like cephalosporins. Also notable because they have a propensity to form brain abscesses, so these can result in really complicated infections. Previously, there was an outbreak of Enterobacter sakazakii, which was associated with outbreaks from contaminated powdered formula. Pseudomonas is an important pathogen in the nosocomial setting, so primarily in preterm neonates in the ICU, where it can be associated with outbreaks as well. As I said, I would show you some actual data from the U.S., and this is a really important data from a really important network that's been sponsored by the National Institute for Child Health and Development, the Neonatal Network, which tracks neonatal disease at really a large number of sites around the country, so it's very geographically representative of the U.S. And I'll point out a couple pathogens, the two big ones that we're talking about. So Group B, of the 370 cases here in total of neonatal sepsis that occurred, early onset sepsis that occurred out of a denominator of about 400,000 live births, you had 159 caused by Group B strep, so that's 43%, and 107 caused by E. coli, so 29%. So almost 75% of the neonatal sepsis and meningitis was caused just by these two pathogens. And then while we often talk about others as being important, like Listeria was only responsible for 2 cases in this cohort, and other gram-negatives, which we often talk about, only responsible for 19 cases. So a little more on prematurity as a risk factor. It's extremely important, and maybe even more important for E. coli than for Group B strep. Again, this is the same data set per 1,000 live births. In the very low birth weight category of 400 to 1,500 grams, the incidence of early onset infections due to E. coli was 5 per 1,000, and that drops to less than 0.1 per 1,000 in the non-low birth weight term infants, non-low birth weight infants. So again, a big difference between premature and non-premature, although that difference is still there for Group B streptococcus. It's a little less pronounced than for E. coli. So moving on to clinical manifestations, there are a few points that I think are really more important than any others. One is that the symptoms of neonatal sepsis are unfortunately very protein nonspecific. Any sort of dysregulation of temperature, either fever or hypothermia, or even in the setting of a neonatal intensive care unit or under a radiant warmer where there has to be a change in the settings of the warmer, that would be potentially a clue to neonatal sepsis. Really, any unusual pattern of activity is a potential clue to neonatal sepsis. That includes changes in breathing, feeding, or level of alertness. So all of these need to be regarded as possible signs of systemic infection in neonates. Also, it's important to know that it's really impossible to differentiate between fever or hypothermia caused by life-threatening or non-life-threatening infections in the first 28 days of life. So you're unfortunately never able to dismiss fever or hypothermia as benign in a neonate. And that's really led to our current practice of treating all neonates with fever or hypothermia as having serious infections until proven otherwise. So I think, given what I've just said in the last two slides, the clinical manifestations are numerous and all fairly nonspecific. In addition to temperature instability, respiratory distress is a potential sign of sepsis, apnea and bradycardia, what we often call spells in neonates. And particularly, you need to be attuned for either non-preterm infants having apnea or bradycardia, or an increase in spelling in a preterm neonate that's already having some spells. Could be a sign of sepsis. Certainly lethargy, poor feeding, irritability, and also diarrhea is a potential sign of neonatal sepsis. So I think if you're going to err on evaluating neonatal sepsis, it's certainly better to err on the side of having increased suspicion, and if you're considering the diagnosis, then ruling that out. Now, unfortunately, the exam findings are also generally nonspecific with neonatal sepsis. So neonates with serious bacterial infections, including sepsis, meningitis, urinary tract infections, often have nonfocal exam. For example, the classic sign that we think of with meningitis is nuchal rigidity, or perhaps in neonates a bulging fontanelle, but in reality, less than 28 days, less than 20% of neonates with meningitis have either a bulging fontanelle or nuchal rigidity. So these signs are not very helpful at all. That being said, don't want to dismiss the importance of a thorough physical examination, and you're looking in these cases for other potential sources of infection and complications. And so some of the bacterial infections that can present with localizing signs in neonates include pneumonia, musculoskeletal infections, including osteomyelitis and septic arthritis, cellulitis, omphalitis, and necrotizing enterocolitis may all present with some exam features. You're also looking for non-bacterial potential things on your exam, so a thorough skin exam is important. This is an infant who's got a vesicular rash, so a neonate with a vesicular rash. I mean, this is pretty easy and obvious. One thing that you have to consider in the differential for neonatal sepsis is also HSV infection. In some of these cases, the rash could be much more subtle. So, for example, this is a neonate with a much more subtle rash, vesicular rash that had HSV infection. So that's an important clue. And here's another obvious one. Here's a baby with omphalitis. This is necrotizing fasciitis of the abdominal cell wall that extends through the umbilical vein and can involve liver and other structures as life-threatening. Of course, you wouldn't miss this on exam, but I don't have a picture of it, but much harder to find on exam is osteomyelitis, so a baby that's not moving an extremity, a baby that's in a neonate that's in pain in a certain area could have a septic arthritis or osteomyelitis. That could be a very valuable clue as to what's going on, and a setting where maybe surgical intervention would be needed in addition to antibiotics. So the exam is really important. Now, what about ancillary laboratory tests? So the initial management is really not based in any essential way on blood tests, but these can provide important clues. So the CBC, in early onset sepsis, you're typically looking at low white blood cell counts, neutropenia, a high ratio of immature to total neutrophils, and immature neutrophils are band forms, metamyelocytes, all immature forms. A high I to T ratio would be 0.3 or higher, would suggest the preponderance of immature neutrophils, and that suggestive of potential infection. Low platelets may be another sign of neonatal sepsis. Now, in late onset neonatal sepsis, it's common for the white blood cell count to be low, but it's also common for it to be elevated, like we typically think about with an older child with a serious bacterial infection as often having a high white count. That's not the case with typically with neonates with early onset sepsis. CRP has been studied as a marker for neonatal sepsis. It's typically elevated in serious bacterial infections, but again, this is not a super specific test. Chest X-ray imaging are very good tests for evaluating neonates with potential sepsis. But again, none of this is really, this can give you clues, but it's not at the core of what you're doing. What is at the core is the microbiologic evaluation, so this is really essential. It's essential that you have a blood culture that's an adequate blood culture. So blood culture is not a perfect test for sepsis. If you have a neonate where you suspect bacterial sepsis and everything else points you in that direction, have to remember that a single blood culture is only 90% sensitive for a bloodstream bacterial infection in a neonate. So it's very legitimate to continue antibiotics past the point of 48 hours or 72 hours of a negative blood culture if you feel that the clinical course is compatible with sepsis. However, with the blood culture, you want to try to draw a minimum of 1 ml and optimally 2 to 3 mLs, because with every drop of blood extra that goes into the blood culture, your sensitivity is improved. Lumbar puncture, lumbar puncture is an important part of the workup for neonates with suspected sepsis. I think it's essential, and it's really especially essential because blood cultures are negative in 40% of infants with meningitis. So you can't rely on a blood culture alone. You have to do a CSF culture as well. And then urine cultures and stool cultures can be important as well in identifying a microbiologic cause of sepsis. Other things on the differential beside bacterial infections for a neonate with symptoms that are consistent with sepsis include other viral infections. So a neonatal enterovirus infection can be profound, mimic sepsis. HSV, as I've already mentioned, and I'm going to come back to several times in this presentation, can mimic neonatal sepsis. Congenital infections, classic congenital infections, which is the topic of the second half of this talk, usually in severe cases they can present with a sepsis-like syndrome, but they're often quite identifiable, and we'll come back to that. Non-infectious causes could be metabolic disease, inborn errors of metabolism, neonatal respiratory distress, congenital heart disease. Those are all important things to consider in your differential diagnosis of a neonate that seems to be septic. So what about management? In the early stages, as I've said, you want to err on the side of evaluating and ruling out whenever you are dealing with a potential case of neonatal sepsis. And you're dealing with a disease with a high potential for fatality, as we discussed. So at minimum, CBC blood cultures, lumbar puncture, CSF cultures. While you're doing this, and if you have a delay in doing those things, you can start empiric antibiotics. Starting antibiotics early is probably the most important thing that you can do to help with the outcome in these cases. In the case of asymptomatic neonates who have risk factors for sepsis, you can utilize certain prevention strategies that have been endorsed by the American Academy of Pediatrics, and I think I'll come back to that in a few slides. In terms of empiric antibiotics, the classic regimen for neonatal sepsis while you're awaiting your results of your evaluation are ampicillin and gentamicin. And the rationale for this are, this is a really good combination of antibiotics for group B streptococcus, which, as we saw, is the most common cause of neonatal sepsis. Group B streptococcus is never resistant to ampicillin. The gentamicin provides some synergy for rapidly killing this organism. So that's a good regimen. This regimen also covers listeria, and that gets some play in the discussion of why it's a good regimen. But given how rare listeria is, I'm not sure that should be considered as an important reason. But it is very useful to know that cephalosporins do not at all cover listeria, and ampicillin is a very effective antibiotic. It's the ideal antibiotic for listeria. So that's another plus for this regimen. And between ampicillin and gentamicin, you are able to cover most other gram-negatives. Now, some additions or alternatives that you might consider in special scenarios would include vancomycin. So if you're considering Staph aureus in the differential, vancomycin covers that, including methicillin-resistant Staph aureus, MRSA. So if you have a neonate who's septic, who has signs of cellulitis or mastitis, or some suggestion that this may be more likely to be a staph infection, then you certainly want to have vancomycin, assuming that you have high enough incidence of MRSA in the community, which frankly I think most, if not all, communities do. Nafcillin is an alternative for MSSA. Flagyl is an important consideration to if you're suspecting anaerobic infection might be possible. There are a few reasons why you might think that. Certainly in the case where you have a gut source, you'd have to consider anaerobic infection. And then cefotaxime is a common addition to the regimen of ampicillin and gentamicin, or occasionally a regimen of ampicillin and cefotaxime are given. This is something you really should be doing if you suspect gram-negative rods up front. For instance, the mother's culture group gram-negative rods. You saw gram-negative rods in the CSF on the LP. I would highly recommend starting cefotaxime up front, and that's just because so much E. coli is now ampicillin resistant. It really, you'd be better off with the third-generation cephalosporin. And then carbapenems are a very acceptable drug for neonates with sepsis, and this is something you'd want to consider if you're trying to get anaerobic coverage, if you're trying to cover extended spectrum beta-lactamase resistant gram-negative rods. Carbapenem, and particularly meropenem, I would suggest for neonates over imipenem, since imipenem is a higher risk of seizures associated with that. So that's empiric therapy. Once you have an organism identified, then you're really able to tailor therapy to that organism in particular. So for group E streptococcus, it's recommended to tailor to penicillin, since this organism's susceptible to penicillin. However, ampicillin or cefotaxime are alternatives. And one more note about the cefotaxime. So why that as opposed to ceftriaxone? Well, ceftriaxone is not it's not recommended in neonates because it can displace bilirubin and result in higher bilirubin levels and possibly kernicterus. So that's why we use cefotaxime as opposed to ceftriaxone. E. coli, as I mentioned, or other gram-negatives, you'd want to generally be using, at least until you have susceptibility results, a third-generation cephalosporin. For listeria, ampicillin's a preferred antibiotic. An alternative might be vancomycin. For extended spectrum beta-lactamase resistant gram-negatives, carbapenems would be appropriate. And then for staphylococcus, either nafcillin for MSSA or vancomycin for MRSA. So what about prevention? There are very meticulous and well thought out guidelines for prevention of neonatal sepsis, and particularly early onset group B streptococcus infection. And I'm not going to go into detail on the criteria for management of the pregnant women, since that's going to be primarily managed by obstetricians, not pediatricians. However, it's worth probably knowing some of the criteria for intrapartum group B strep prophylaxis. And the goal is to deliver antibiotics during the intrapartum period at least 4 hours prior to the delivery to effectively prevent transmission of group B streptococcus. So some of the reasons include previous infant with group B strep, that's a risk factor, group B strep bacteria during any time in the pregnancy, positive screening late in gestation by culture, and then these are the other risk factors that are related to the status of the mom at time of delivery. So prematurity, prolonged rupture of membranes more than 18 hours, maternal temperature. These are all reasons to administer antibiotics to the mother to prevent early onset group B strep. Now, there's a whole algorithm for dealing with the infants, and this is certainly something that would need to be familiar with as a pediatrician. And these are, again, endorsed by CDC, American Academy of Pediatrics, so very well accepted standards. So you can follow the algorithm yourself. It's available in this report. It's available in the Red Book under the chapter on group B streptococcus. But first, are there signs of sepsis? Obviously, for infants with signs of sepsis, you need to do a full diagnostic evaluation and start antibiotics. If there's not signs of sepsis, then did the mother have a history consistent with having chorioamnionitis? If yes, then, and the baby's well, then you have the potential to do a more limited evaluation, forego the LP, just a CBC, blood culture, and initiate antibiotic therapy while you're awaiting those results. If the mother didn't have signs of chorioamnionitis, was group B strep prophylaxis indicated? If yes, then was it administered adequately more than 4 hours before delivery? And if it was, then you could observe the infant. If not, then you look at some of the risk factors, and that dictates your management. So was this a preterm delivery? Were membranes ruptured for a prolonged period? If the answer is yes to that, then if the answer is no, that membranes weren't ruptured for a prolonged period and the baby was not preterm, then you could observe. But if the answer is no to that, then you'd be then it would be recommended to do again a limited evaluation if the baby looks well, and observe off antibiotics while your blood culture is pending. So those are important guidelines to be familiar with. And if you can't remember them all, they should be near the tip of your fingers with those resources. So before we leave the topic of neonatal sepsis and talk about some of the congenital infections, I wanted to go over a couple of common questions. So here's a scenario. A 21-day-old neonate's rectal temperature was 38 degrees Celsius, but she was heavily bundled. Can the fever be attributed to bundling? Does this baby need a full court press with lumbar puncture, blood cultures, and antibiotics? Again, I think it's better to err on the side of caution because of the potential devastating consequences of neonatal sepsis and the not so devastating consequences of a 48-hour rule out, balancing that. But in this case, bundling can result in some increased temperatures. I certainly would not attribute any temperature greater than 38.5 to bundling, but a single rectal temperature of less than 38.5, in that scenario, for a normal infant who hasn't received antipyretics, it might be reasonable to recheck a temperature in 15 minutes. And if that's normal, the baby's well, hasn't received antipyretics, I mean, that might be a scenario where you could recommend just observing, and if the baby continued to do perfectly, not initiating sort of the full court press. But in most scenarios, you want to err on this side of doing the full court press. Here's another scenario. So a term newborn is born in the setting of maternal chorioamnionitis and discharged after 48 hours of antibiotics, presents with fever and apnea on day of life 6. The infant is intubated and requires aggressive supportive measures. Blood cultures grow ampicillin-resistant E. coli. The team is unable to do an LP on admission. The baby's too unstable for that. So is it worth doing an LP, say the next day or the day after that, if the infant is sufficiently stable? And this question has been asked many times. The answer, in my opinion, is definitely yes. So the diagnosis of meningitis is going to affect the duration of antibiotics. It's going to require a much more prolonged course. It would also change potentially how you monitor this infant, what complications you might be looking for. Now, certainly you can treat, and you should treat the baby empirically for sepsis and meningitis while you're waiting to do the LP, but and while you do that, you may diminish the utility of your cultures, but you still have other CSF indices. You can look at the glucose, protein, and cell counts, and if those suggest meningitis, which they still should 1 or 2 days after antibiotics, that can be quite helpful with your management. So one last scenario, a 21-day-old presents with fever to 100.7 and lethargy, non-focal exam. On the LP, there's 82 white cells, 14 red cells, glucose of 48 and protein of 83, negative gram stain. And my question with this scenario, or the question that's often asked with this scenario is should the baby get acyclovir? And, this can be a hard question, and people may have different answers. It's important to recognize that while neonatal HSV is rare, it's important to treat it early. And again, it's another scenario where you want to err on the side of maybe treating a few babies that don't have it to make sure that you've covered all the ones that do. So it's very important to recognize that maternal history is most often absent. There may be no skin manifestations in neonatal CNS HSV disease. So in my opinion, the indications for empiric acyclovir include any skin manifestations, elevated LFTs, any neurologic findings, or CSF pleocytosis. So in this case, we're talking about a lethargic baby with CSF pleocytosis. I think it meets criteria to get acyclovir and order an HSV PCR from the CSF to rule that out, even though it's not that common. So I'll transition in the next part to congenital infections. Congenital infections, in contrast to what we were just talking about, infections acquired perinatally or at birth or shortly thereafter, congenital infections are generally acquired in utero. Or by definition, they're acquired in utero. Now, both late acquired congenital infections and perinatal infections may present around the time of birth or shortly thereafter with an acute or fulminant course. But the classic things we think of as congenital infections are those which are acquired early enough in utero to present with signs of a chronic infection at birth. The late acquired in utero infections can very well mimic neonatal sepsis, but those acquired earlier have really a different constellation of findings. As we go through a list of these infections, you'll see that there are many, many similarities in their presentation. The classic acronym for congenital infections to help remember the causes of them is TORCH. People often will call these just TORCH infections. So what does TORCH stand for? Toxoplasmosis, other, which usually get syphilis in parentheses, rubella, cytomegalovirus, and herpes simplex virus. But I've already talked a little bit about herpes simplex virus, HSV, and that to me is not really the same because only 4% of HSV infections are acquired earlier in utero. Most of those are acquired perinatally. However, since it's important and often falls in this category, I'm still going to talk about it a little bit more. I'm also going to talk about HIV, which is also acquired much more often perinatally than in utero, but it's just so important I want to do at least one slide on that, and parvovirus B19, which is an important cause of infectious cause of fetal demise and hydrops. So I'm not going in the order of torch. I'm going in partially the order I think is most important. And I'm going to start with CMV because this is by far the most common cause of congenital infection. First of all, CMV is essentially a ubiquitous virus. It's, most people are infected relatively early in life, and it's the most common congenital infection. So 40,000 congenital infections in the U.S. alone, 1% of all births. It is the leading cause of sensory neural hearing loss in the U.S. Now, fortunately, the majority of infants with congenital CMV infection are completely asymptomatic. However, even those that are asymptomatic at birth have some risk for developing subsequent hearing loss and potentially other neurologic deficits over the course of the first year of life. Only a minority, 10%, are actually symptomatic at the time of birth, and those are certainly associated with a risk of worse outcomes than the asymptomatic group. So in terms of congenital CMV, maternal primary infection, meaning if a mother acquires CMV during pregnancy, that results in the highest risk of infection to the fetus and also the highest chance of sequelae to the fetus, much more likely to have severe disease. However, it can be passed on to the fetus through reactivation of maternal disease, so a mother can acquire CMV earlier in life, have a reactivation of their infection since it stays dormant in the body once you're infected for the rest of your life. If the virus replicates and you get viremia, there's a very small chance in that scenario of passing infection onto the fetus, so less than 2% in that scenario. And in those scenarios, sequelae of infection are infrequent as well. So primary infection in moms is the real bad actor. In terms of mode of transmission, it can be transmitted transplacentally, and this gives rise to the classic congenital syndrome of congenital infection and increased risk of sequelae. It can also be transmitted at birth or even postpartum by breastfeeding. In that scenario, there's really no long-term sequelae. It's a benign infection typically. And in the intrapartum scenario, again, it's very much most likely to be benign. So in terms of the clinical features of congenital CMV, I mentioned that asymptomatic infants are at risk for hearing loss. That's about 10% of those asymptomatic infected neonates will develop hearing loss. Symptomatic CMV is characterized by hepatosplenomegaly, jaundice, and petechiae. Hepatosplenomegaly in general is a sign of chronic infection. In severe disease, there's neurologic manifestations as well. So chorioretinitis is a classic manifestation of CMV disease. Microcephaly, cerebral calcifications, and intrauterine growth retardation, IUGR, is a manifestation of more severe symptomatic congenital CMV. And at the very worst end of the spectrum, you can develop a fulminant, neonates can develop a fulminant illness, which not only has all these features, but also presents with a sepsis-like illness, which is just basically an overwhelming viremia and associated with multi-organ failure. This is, unfortunately, a very sad, picture of just such a case of fulminant CMV. But I wanted to show it because this illustrates the classic rash of congenital CMV, which is called a blueberry muffin rash. And what you're seeing in these spots are signs of normally erythropoiesis in fetal life happens in the liver and in the bone marrow, but in infants with severe congenital infection, it happens actually in the skin, and that's what gives rise to this very classic rash. So this is an image taken from the Red Book chapter on CMV, and I'll just mention, since I don't think I mentioned before, the Red Book, as you probably most of you know, is the American Academy of Pediatrics authoritative guide to infectious diseases. So if you're going to read on these topics, that's really a great authoritative source and very helpful for management. In addition, it has a number of images which are quite useful as well for learning about these. Now, this is another image of a baby with a congenital CMV infection, and you can see here that this is a much more mild manifestation of the skin rash, although you can see some petechiae and purpuric lesions, and thanks to the marks here, you can see that this baby also had hepatosplenomegaly. So this is the more mild but symptomatic case, and the last one was the fulminant disease. So in terms of diagnostics, the most important thing is to consider the diagnosis and send diagnostic tests early in life. If you send diagnostic tests after 4 weeks of life, then you really can't distinguish between virus acquired in the uterus and virus acquired after birth. And congenital infection, a diagnosis of that requires that the infection is acquired in utero. The classic gold standard for this is a shell vial culture of the urine. However, a number of studies have shown that PCR is also a very sensitive and specific test. Again, it has to be done during the newborn period to rule in or rule out congenital infection. For babies with suspected congenital CMV, certainly the workup would typically include labs, including a CBC and differential, liver function tests, lumbar puncture, ophthalmologic exam, and head imaging, given the symptoms that I just discussed. Fortunately, there are effective or antiviral therapies which have been shown to provide some benefit in CMV. These certainly aren't a panacea or cure-all. It's still possible to have poor outcomes, but in studies with infants with symptomatic CMV, ganciclovir administered for 6 weeks has been shown to significantly decrease hearing impairment and reduce developmental delays. Unfortunately, it hasn't really been studied sufficiently in asymptomatic infants who have some risk of going on to have hearing loss. It also hasn't been studied in a clinical trial that's been yet reported in infants with only isolated hearing loss. So in these scenarios, it may be more controversial as to whether to give ganciclovir, and hopefully there'll be trial data coming down the road to help determine that. In addition, there's increasing evidence that the pharmacokinetics of valganciclovir in neonates allow for administration of oral valganciclovir, which it can be essentially equivalent to intravenous ganciclovir. It takes away the morbidity of having to have prolonged intravenous access, although it doesn't get rid of the potential morbidities of neutropenia, which is the major morbidity of the prolonged ganciclovir. And it's also potentially a nephrotoxin, although complications due to that are more rare than neutropenia. So looking at these drugs and more prolonged courses are areas of active investigation, and that practice may be changing. So this is important to consult with experts when you're faced with these scenario infectious disease consultants, and the Red Book would be a good place to start to keep up to date in terms of current recommendations. Congenital HSV. So I've already touched on this topic in terms of its ability to mimic neonatal sepsis. So that's caused by HSV virus types 1 and 2. It occurs, as I said, it's relatively rare. It occurs in 1 to 3,000 to 1 to 20,000 births. Most cases are acquired during the perinatal period. In utero infection is rare, about 4% of cases. The highest risk of acquisition is during primary maternal infection. This is really true of, I just said it was true of CMV, so mom with the first CMV infection, initial CMV infection, has highest risk to transmit it to the fetus. And that's really the same for all these congenital infections, because maternal history of having this infection before likely conveys enough of an adaptive immune response to help prevent its transmission to the fetus. So this is really important for congenital HSV because people often think, well, if there's no maternal history of HSV, that's a lower risk for the infant. But in fact, it's really, you wouldn't expect a mother to have a history of recurrent herpes since acquisition in that scenario is quite rare. It's much more likely to be acquired during the primary infection. Neonatal disease with HSV is categorized as disseminated multi-organ disease. In patients with this, they'll typically present around within the first week of life. They'll have multi-organ failure, sepsis, increased LFTs. Another form of the disease is localized to skin, eyes, and mouth. This has the best outcome. This also typically presents within the first week to 2 of life. And then there's also localized CNS disease, and this can be a very highly morbid or potentially fatal disease. It's interesting that this is typically later onset, so typically happens around 3 weeks after birth. In cases of congenital HSV or perinatal acquired HSV, there's a benefit to IVA cyclovir, and typically a course of IVA cyclovir is followed by prolonged suppression. Ocular involvement also requires a topical therapy. So one frequently asked question related to HSV and neonatal HSV. So here's a scenario. An apparently healthy term neonate is born to a mother who's noted to have genital lesions during the delivery. She has a previous history of genital herpes. So does this asymptomatic neonate need to be evaluated or treated empirically for HSV? And the answer is that this is actually not an area where all experts are in agreement. Most experts do recommend sending HSV cultures at 12 to 24 hours of life, so at least sometime after birth. And some experts also recommend starting acyclovir in these cases while HSV cultures are pending. Now, in this particular case, the fact that this mother has recurrent disease means they're much less likely to pass it on to the infant. A primary maternal infection, so a woman who has a first episode of genital lesions at the time of delivery, would be quite concerning. In that case, most experts would recommend starting acyclovir while waiting for the results of the cultures. And then if the cultures are positive, then a full-bore workup, including the lumbar puncture, labs, and a prolonged course of IVA cyclovir would be indicated. Okay, so toxoplasmosis, the T in torch. Toxoplasmosis gondii. Cats are the definitive hosts, but oocysts can infect many warm-blooded animals. The major risk factors for toxoplasmosis are consumption of raw or undercooked meat or contact with cat feces. And congenital toxoplasmosis occurs in the U.S. at what's thought to be approximately 1 in 10,000 births. 70 to 90% may be asymptomatic, so that's fewer than in CMV, but it affects a much, much lower number of births. Now, with increasing gestational age, there's an increased risk of infection, but a decreased risk of severity. So during the first trimester, if the mom has a primary infection, there's a very low chance that she'll pass that on to the fetus. However, if they do pass it on in the first trimester, greater than 80% have a very severe debilitating outcome. And the converse is true. So in the third trimester, there's a much greater chance of passing it on to the fetus, but a much lower likelihood of a severe outcome. What are the symptoms of congenital toxoplasmosis? Microcephaly, hydrocephalus, intracranial calcifications, and particularly note the hydrocephalus, and that's something that distinguishes congenital toxoplasmosis from congenital CMV. Chorioretinitis, although the lesions may look different in character than the ones associated with CMV, which are the classic cotton wool spots. Hepatosplenomegaly and jaundice, these are features that are shared with different congenital infections. Lymphadenopathy, thrombocytopenia, again, those are shared with other congenital infections. There's manifestations of prolonged intrauterine infection. In terms of the diagnosis can be made by IgA or IgE in cord serum, or isolation from the placenta or blood, or isolation of the organism from placenta or blood. A common option is the Toxoplasma IgM or PCR from the Buffy coat, or CSF or amniotic fluid of the infant. A thorough exam, neuroimaging, lumbar puncture, hearing screen are indicated in any case of suspected congenital toxoplasmosis. And in Massachusetts and some other states, it's part of the newborn screening. It's certainly part of routine prenatal screening in countries where there's a higher incidence of congenital toxoplasmosis, like France and Austria. The treatment regimen is extensive, prolonged, pyrimethamine, sulfadiazine, folic acid. That's a standard regimen for congenital toxoplasmosis. This really is something that should be done in consultation with an expert in pediatric infectious diseases, because the toxicity are substantial and it requires prolonged monitoring. Prednisone is an adjunctive therapy until the CSF protein decreases in congenital toxoplasmosis, so that's a very important component as well. Congenital syphilis. There have been an average of 200 to 500 cases per year in the U.S. over the last decade. That translates to an incidence of about 8 to 10 per 100,000 live births. About 1/3 of these cases involve our infants, neonates born to women with no prenatal care, which of course means that 2/3 did have some prenatal care, yet things happened so that an opportunity was missed to prevent transmission of syphilis to the infant. And like other congenital infections, there's increased transmission with increased gestational age, but decreased potentially decreased severity. So a high chance of perinatal death in infections acquired during the first trimester, a higher risk of transmission in the third trimester, but potentially lower morbidity. That's if it's caught and treated early. So clinical features: fetal infections, stillbirth, hydrops, prematurity. Neonatal infection can be asymptomatic, and in these cases, it's important to identify those infants at risk and treat them through screening, but it can prevent with multi-system disease. And some of the classic features of congenital syphilis include snuffles, desquamating rash, and periostitis. And the rash associated with syphilis is one of the more specific features. Some of the more general ones that are seen with other congenital infections, again, include hepatosplenomegaly and adenopathy. In infants with unrecognized congenital syphilis, you can go on to develop later manifestations, including CNS disease, abnormalities of bones and teeth, eyes, persistent rashes, and this can give rise to significant deformities later in life, like saddle nose, saber shins, and Hutchinson's triad, which is keratitis, notched incisor teeth, and a cranial nerve 8 deafness. I wanted to focus on just the neonatal manifestation, since that's the main subject of this talk. So this is an example of infants with snuffles, which is discharge from the nose, mucous membrane involvement. There's often some hemorrhage at the nares. You can see severe mucous membrane involvement in this infant, a little less pronounced in this neonate. This neonate has some swelling of the wrists and arms associated with periostitis, and that can be quite painful, and that can be something you can observe on exam as well. And unfortunately, neither of these infants really shows the desquamating rash very well, but that might be especially prominent on hands and feet. There can even be some ulceration, ulcerative type lesions, and those would be highly infectious. This material is highly infectious as well. So in terms of evaluation, certainly any suspected case, you'd want to be an abnormal exam, a serum RPR or VDRL 4-fold greater than the maternal titer, dark field or DFA positive from body fluid. That would be essentially cinch the diagnosis. And then to evaluate an infant where you suspect congenital syphilis, it would be recommended you perform CSF evaluation, CBC, X-rays to evaluate for osteochondritis, ophthalmologic exam, hearing screen, and a cranial ultrasound or other cranial imaging. Now, more often than seeing an infant with suspected disease, you have a scenario where you know the infant is at risk for exposure based on maternal history of having syphilis or being screened positive, and all pregnant women should be screened for syphilis. Now, there is a fairly complicated algorithm for managing syphilis-exposed or potentially exposed neonates. These are guidelines. This algorithm is a guideline of the American Academy of Pediatrics. It's in the Red Book under the syphilis chapter. So anytime you're dealing with a mom with a positive test or history of syphilis, and if you're unsure that you remember this algorithm, this is a very handy reference, or you could consult an expert if you're feeling unsure. But sort of the nuts and bolts of it are, if a mother has a risk of syphilis and not adequately treated with antibiotics herself during pregnancy, then you would evaluate the baby and potentially give a course of antibiotics. And then in cases where the evaluation is concerning or the maternal history meets certain criteria, then you would just do a full course of treatment and evaluation for the infant. So I'm not going to go into the full algorithm, but it's an important resource, and it's really essential that all these cases be prevented. So moving on to congenital rubella syndrome. Rubella is normally a very mild virus infection for adults and older children. It's an RNA virus. Now, up to 25% of women of childbearing age have no immunity. There's very high attack rates in susceptible people who are exposed. immunity is not necessarily lifelong, and reinfection is possible. The lack of complete immunities to rubella is one of the reasons that led to the recommendation of having 2 doses of MMR. Since vaccination became common in the U.S., the incidence of congenital rubella syndrome has dropped enormously. The last major epidemic of this was in the 1960s. Now it's quite rare in the U.S., which is why I'm not going to devote a lot of time to it. However, it's associated with a very high risk of defects if pregnant women are exposed and acquire rubella early in pregnancy, especially in this first trimester, where up to 85% of congenital infections acquired at this time have subsequent defects. So congenital rubella syndrome, a lot of the manifestations are similar to other congenital infections: intrauterine growth retardation, developmental delay, hearing loss, retinopathy, hepatosplenomegaly, blueberry muffin rash, osteitis, periostitis. But the one that really stands out for congenital rubella are congenital defects, congenital heart defects, including patent ductus, arteriosus, and pulmonary artery stenosis. So vaccination is what really prevents this, and the rubella component of the vaccine is not to prevent rubella, it's to prevent congenital rubella. The virus in congenital rubella is present often for a long time, many months or even more than a year. So viral culture is sort of the standard for diagnosis, but can also be diagnosed by rubella IgM and infant serum, and unfortunately care is supportive. One thing I'll just mention is that even though no cases of congenital rubella syndrome have been reported arising from vaccination with MMR, which is a live viral vaccine, it's still not recommended that MMR be given during pregnancy for concern, theoretical concern of complications related to congenital infection from the attenuated virus. So just to hit a couple highlights of the clinical features, a lot of people struggle with the different features of the different congenital infections, and I actually think people struggle to remember a distinguishing feature of each type of torch infection. I actually think it's more useful just to be aware of the things that are in common that should make you think of congenital infection in general and pursue a workup, because you can certainly pursue a workup for all these things. All these things are testable. You could do diagnostic testing for, and a lot of the workup is shared in common between these different congenital infections. But that being said, some of the classic features of each: microcephaly associated with CMV, heart defects associated with rubella, hydrocephalus associated with toxoplasmosis, and the particular exanthem, the desquamating rash that's associated with syphilis. A couple other things just to touch on quickly, and then we'll be done. So parvovirus B19. About 50% of women of childbearing age in the U.S. are IgG negative, so susceptible to this virus. There's an average of 1.5% per year seroconversion. 50% of exposed susceptible individuals become infected with a peak viremia at 7 days. A maternal primary infection is unfortunately associated with a risk of fetal intrauterine growth retardation and heart failure and hydrops fetalis and fetal loss. And the greatest risk is in the first half of pregnancy, where there's a 2 to 6% risk of fetal death associated with maternal infection. Postnatally, there's no major complications or issues with this virus. The diagnosis can be made by IgM in the infant. And HIV, there's very rarely in utero transmission of HIV. Most HIV infections are perinatally acquired. So it doesn't quite fit into the category, but it's just so important because it's very preventable. So it's important that mothers be screened. If they're at high risk, they can be screened multiple times during the pregnancy. For mothers who are HIV infected, screen positive, both pre, peri, and postnatal antiretroviral prophylaxis are all are three arms of the preventative strategy to prevent HIV transmission. And with this approach, there's very, very low rates of transmission of HIV vertically. We also would recommend the use of molecular diagnostics for neonates born to infected mothers to make early diagnosis. So some of the older practices relied on serologic testing, but now with advances in nucleic acid testing, DNA PCR, ultrasensitive RNA PCR, there's no reason these diagnoses in the neonates can't be made early. And breastfeeding is contraindicated, of course, in developed countries. I'm not going to go into specific details because guidelines change, but for authoritative guidelines for prevention of perinatal HIV transmission, the AIDS Info website of the NIH is sort of the authoritative location.